Welcome to Nagaland TV. So manu naga awas. India de sashikuli to America naga state Nagaland top 2 de rank kuri itu HIV/AIDS status de. Inaga homoide Nagaland Police Referral Hospital Chumoukedima de aji ekta launching program takishe. Ari itu launching program do ki karne ase kushukuli to Opioid Substitution Therapy OST Centre laga launching program takishe in collaboration with Nagaland State AIDS Control Society NSACS kanote. Aru itu do mainly for tawai kha manu aru drugs kha manu kan karne ase kuina bi amian ki janai dishe. Aru itu OST Centre do Nagaland the first OST Centre ase kuina bi amian ki janai dishe. Aru itu launching program de Shri Rupin Sharma IPS Director General of Police Nagaland do special case takishe. To IB itu launching program da opor details sai sawa.
One of the key harm reduction initiative of opioid substitution therapy is the intervention that reduces the risk of HIV transmission by providing safer alternatives to illicit opioid drug use. By mitigating the spread of HIV among people who inject drugs, harm reduction helps in reducing broader community transmission of the virus. Harm reduction is essential for the NSACS of reducing new HIV infection and enhancing the quality of life for people living with HIV and addiction, particularly in regions like Nagaland, where intravenous drug users are the significant driver for its epidemic. NLTV integrates harm reduction into a comprehensive care approach, linking these services to HIV testing, treatment, and counseling. This approach not only addresses the immediate risk, but also facilitates access to long-term health care support, thereby improving overall outcome of those infected and affected by HIV. Illicit drug addiction poses severe harms across multiple dimensions of health and well-being. Physically, it can lead to life-threatening conditions such as overdose, infectious disease like HIV, hepatitis, cardiovascular problems, and organ damage. Chronic use often deteriorates mental health, resulting in disorders such as depression, anxiety, and psychosis. Socially, addiction disrupts relationships, contributes to criminal behavior, and can lead to social isolation. Economically, it burdens individuals with financial instability due to high cost of drugs and impaired productivity. Furthermore, addiction often fuels cycles of poverty and crime, impacting communities and increasing their healthcare and law enforcement costs. On a broader scale, illicit drug addiction exacerbates public health crisis, strains public health systems, and hinders the effort to address diseases like HIV/AIDS, particularly when drug use involves the practices of needle sharing. OST is a critical harm reduction strategy used to treat individuals addicted to opiate drugs such as sunflower, heroin, brown sugar, opiate painkillers, etc. OST involves replacing the illicit opiate drug with a medically prescribed, long-acting and less euphoric, like Sir has rightly pointed out earlier, such as buprenorphine. This therapy helps stabilize the patient by reducing withdrawal symptoms and the craving, allowing them to lead a more functional life. OST significantly lowers the risk of HIV and hepatitis transmission as it reduces the need for injecting drugs, thereby decreasing the practice of needle sharing among people who inject drugs. It also diminishes the chances of overdose, supports long-term recovery, and improves social and occupational functioning. By providing a safer alternative, OST acts as a bridge to comprehensive treatment, including counseling and social support and healthcare services, facilitating the overall recovery process and reducing the broader societal impacts of opiate addiction. Buprenorphine is a key medication in the OST with a unique feature. When administered at the right dose, the correct dose, it can block the effects of other illicit opiate drugs. And it is administered sublingually, that is under the tongue. Buprenorphine, when administered under the tongue, it bypasses the liver during absorption, reducing the risk of liver-related side effects and making it a safe drug for long-term use.
This is a slide all presented, this is a national level master trainer slides given to us through our national trainer agency, the AIMS daily. So we also look at it that they spend a lot of time looking for the drug to satisfy themselves, and then they also, most of the time they find it and then they reach the intoxication stage. And then it picks down because the craving comes in, and then the withdrawal experiences, though they have to go back and search for the illicit drug, and then after that, after about some few hours, again it comes down, and then the cycle continues for, this is kind of a typical regular cycle that a drug user would experience in a day. So So here they buy drug, use the drug, recover from the effects, again experience withdrawal and craving, so get back to the drug. Another is, so here we are looking at other like heroin or maybe sunflower or the brown sugar as the illicit opiate. And then the OST is an agonist medicine. The agonist medicine, which is long acting, medically safe and prescribed and taken by a safer route. And along with this, the psychosocial rehabilitation becomes very important. So that's where the counseling becomes a very important package of an OST program. So here the OST would come and break the cycle. So when OST, we look at OST as something that blocks the receptor in the brain. Okay. In the brain, there's a receptor which craves for opiate substances. The OST is kind of a key that comes and locks it. So the craving is locked. So the OST is looked at for the administration of OST is to lock that craving receptors in the brain. And when that is locked, that person, and then the OST will not intoxicate. Illicit drugs will put a person in intoxication, they'll have euphoria, high. OST will not give them that. So one of the challenges is also that those people who are into drug because they wanted that high, they wanted that experience of being high, intoxicated, it becomes very difficult to retain them to the OST also. But those people who sincerely want to recover and come out of the dependency, come out into recovery, are the ones like we also see sincerely adhering to the treatment. And over the years, it's about 10 years that we have been implementing in the state, almost about 3,000 recovery completion of treatment has been achieved by us also. In the NACO model, National AIDS Control Model, we look at this as an intervention for HIV. But at the state level, we are also looking at it in achieving abstinence, which is recovery. So that is something that we are working on it. To get drug users into abstinence and recovery, psychosocial counseling becomes a very important component, because what we see is that over the years, in our experience, some people are into the OST drug for many years, and some people would exit sooner. But the OST says that the longer they are into, the outcome is better. Because we are preparing them not only for chemical dependency, but we are preparing them for psychological, to exit from the psychological dependency. In few centers, like some of them were with us for like more than 10 years, so we also ask them. But they are taking just a very minimal dose. It's just like we always take rice. Rice is our staple food. Even if someone gives me 10 roti, I'll say, "Bhat khana hai abhi." So their psychological dependency, because of that, these are few people. When we actually looked at them, they are not chemically dependent anymore body, but then psychologically they continue to be dependent. So we try to just give very minimal dose. It's like a placebo dose only, a very minimal dose. And then that's how we try to make sure that they don't slip back to the relapse back to the behavior. So we see that these are illicit opiates will again develop cravings and withdrawals. These are agonist medicine with buprenorphine. This will help in reducing their craving and withdrawals.
I think the first step to solving a problem is to realize that there is a problem. If we don't accept that there is a problem, we will not even look at a solution. Once we realize that there is a problem, the second step should be that the problem is not the end of the world, but it is the beginning of a solution. I think this is where we all stumble, this is where we all fail. Last year, around this time, we conducted an in-house exercise in Nagaland Police of drug users or substance abusers. So basically drug users, we did not want information on alcohol, but some people did share information on alcohol also. And whatever information that we got also painted a very gloomy picture of things. I believe that even in that first phase, we would not have had more than 50% disclosure of people who were drug users, but even with a 50% disclosure, the numbers were very, very high. It was unusually high. I will not want to give numbers here because I don't want a sort of a negative publicity. We know the problem, we will address it, but there is no point in giving numbers. Then we devised a mechanism where we asked the staff to self-declare who were drug users so that we can address their problems. Unfortunately, neither then nor now we have facilities where we can take measures for rectification. That time we did not have any facilities. Slowly we started developing some linkages. Some officers or some staff started going to the detox centers on their own, which is a very welcome step. But the first step that we started in the police department was we gave them some time. You go to the de-addiction center, get yourself detoxified. We will not touch you. We will not do anything to you. We received a very positive response. We had the lists. We sort of did not want to force anyone. But there were a lot of family members who used to come and say, "Amala mota to chhadishi, amala bawa to chhadishi." So it was a good beginning, but it was sort of not delivering the results which were expected. So we tried to be harsher. When we ended up dismissing 12, 13 of our personnel, because we had to show that we will not tolerate this nuisance. The second step again pushed a lot of people to go into the detox centers and for getting themselves detoxified. Again, it was very welcome. However, the problem that we continuously faced was we did not have any facilities in house. And our people are very disciplined, but they are also indisciplined because they cannot be controlled by anyone else except our own officers. So our own system is much better to checking them rather than the civilians. Because I started getting, when I was talking to Dr. Sekose and some other friends associated with NSACS and with detox centers, they realized that some of the most unruly patients that they had at the rehab center were the policemen. So those problems we faced, so we thought that we should have some facilities in-house. Then I discussed with Dr. Sekose and all, and we came up with this idea, let us set up at least 2-3 centers. But to begin with, let's set up one. So here we are with one center today. This center is not only for policemen and their families and dependents. The civilians in and around Chumoukedima, in and around Dimapur, and our police personnel throughout the state are welcome here to avail the facilities. What my friend said in his testimony that he had to wait for 3 months for someone to connect to one of these centers, detox centers. I can assure you that nobody who is in need of detox will have to wait for 3 months. Okay, we will be available all the time. If you have a problem, you have to wait for more than 2 days, 3 days beyond the registration or a general counseling, please get back to us. We want to make it as easy for an ordinary civilian to reach us. Not 3 months. I am not willing to wait for 3 months. 3 months is a long time where if a person has to wait, he was probably sensible enough that he will not go back, but 3 months is enough time where people will increase their dosage and probably some of them will either become very, very heavily addicted or may even lose their lives because of overdose. So we assure you that we will not allow a long waiting period. I think my request to the CMO, SMO and the other staff is, let us not have any waiting period. Anyone who wants to come to the OST Centre, we will be there 24/7 with sort of zero pendency. Ideally, zero pendency for taking a person. And for that, we will need support from NSACS to support us with the OST, with the medications and the counseling and all, so that we don't have a line of a waiting list. So we will endeavor to do that. I mentioned this to the senior officers in the police headquarters that I am willing to look at giving short-term leave or bringing our own police officers and staff on duty to be posted to Chumoukedima and Dimapur area if they are drug users, but with the promise that an independent assessment will tell us that he is giving up the drugs. If there is an abuser whom you know, who is a policeman, a family member, mother, father, children, anyone, we will sort of temporarily, I am willing to temporarily attach them to one of the units in Dimapur or Chumoukedima so that they can avail these facilities. But that is only a temporary phase. I was just talking to Dr. Sekose and I asked him to, when I was bending towards him, I asked him, I said, Kiman din de asar hoi thai, till in how many days we can feel that the OST substitution drug is making an impact. So he also said, he said, in Mahina, 4 Mahina, already some of them have been there for 8, 9 years, 10 years also. But I think I am willing to look at a 4-month window as a progress window, 3 to 4 months window as a progress window, where say someone starts with say 28 tablets, but in 4 months he comes down to 6 or 7 tablets, something like that. Okay, a progressive incremental improvement in his approach towards drugs. If he does it, maybe we can look at another 2 months of his attachment or posting in Dimapur or in Chumoukedima or Dimapur area so that he can recover fully. But if in this 4 to 6 months period that he is attached here, he goes back to the drug, there is no mercy, he is gone, he will lose his job. I am willing to consider giving enough leniency to all of you, to all my friends in the police department, to help you to overcome the problem. But if you don't want to change, I don't want you. No? If you don't want to change yourself, I don't want a department which is full of criminals, which is full of drug abusers, where someone can give you an allurement of 2 doses or 3 doses and say to Manike Goli Morai. These are likely scenarios, okay? So I am willing to give an opportunity to anyone, family members or our own policemen, please come up to us, disclose to us that you want to go to the rehab. So first undertaking we will take is that I will sincerely do it. We will take an independent assessment from the team here. If he is reducing, maybe another 2 months or something will continue, but once he is okay, he goes back to his unit. This is only for enabling you to get treated and not a permanent posting here. If you think that you will continue here for 10 years, because you will to take OST for 10 years, it will not be done. Okay, it's only for a maximum of 5 months, 6 months, but that 5 to 6 months will depend on the initial progress in the first 3 to 4 months. Then we'll do that. So my appeal to everyone of my police personnel here is, if you are an abuser, please self-disclose and come. We will help you.
Nagaland TV, Sop Manulaga Awas. Watch us live on Geo TV and on your television sets as well. For Dimapur viewers, we are on channel number 994 in Global Chapter, and Kohima and Mokokchung viewers, switch to channel number 138 on Hornbill Digital. For all news and updates, follow us on Facebook, Instagram, YouTube, and Twitter.